Coronary artery disease, or CAD, is one of the main causes of mortality among the adult population. The Cardiac Care Network of Ontario reported over 5,000 cases of treated ST elevation myocardial infarction in 2015 to 2016. Patients who have drug-eluting stents implants as treatments are prescribed dual antiplatelet therapy, or DAPT, that includes aspirin for life and a secondary medication, either Clopidogrel or Ticagrelor, for 1 year based on the current guidelines. Increase in medication spending from pre to post-MI can vary annually. The problems perceived are the increase in medication spending, the one standard therapy protocol, and lastly, nursing knowledge of DAPT treatment is only through the word of mouth. Therefore, I created a Pico question for my research topic seen on this slide. Using several journal databases to search for evidence, I found 3 random controlled trials, 1 systematic review, and an unpublished literature. I created a summary of findings and information of each studies found. Results show that unstable patients that have coronary artery disease with stent implants require 12 months of DAPT therapy, and for the stable CAD patients with implanted stents, 6 months of DAPT is insignificant to 12 months. One indicative factor important in choosing the duration is bleeding. My intervention is to create and implement a DAPT algorithm for my work setting. The target population are the stable and unstable CAD patients that are treated with DES implants. The DAPT risk bleeding tool is used after completion of the initial therapy to guide the clinician if prolonged DAPT is safe for the patient in terms of bleeding risk. The target users of the algorithm are the cardiac interventionalists and nurses involved in the local hospital cardiac care. Carter's 8 steps to change model will be used for my intervention. I will attain buy-ins from stakeholders and team members for support of the intervention. Aligning with the current vision of leading in cardiac treatment and prevention, I will promote champions to empower clinicians and nurses to utilize the DAPT algorithm. Although a barrier such as a resistance to change can occur, I will use the Myers-Briggs tool assessment to strategize how to approach individual team members and communicate efficiently to sustain the momentum of the transitional change. As this intervention is the first of its kind in the local hospital, I have purposely left room for future developments once cultural change is accepted. This intervention is a guided tool in determining the DAPT duration post-stent implants for CAD patients. More importantly, a holistic process of looking into the biopsychosocial readiness of the patient is also important for successful medical treatment. Thank you for listening.